The outline of management of type 1 diabetes in children. These are my agenda. First, the incidence of diabetes is about 1,800,000 per year under the age of 15 years, rising at 30% per year. The prevalence of type 1 diabetes is about 5 to 10% of all diabetics. The etiology. There are three categories of diabetes: type 1 diabetes due to beta cell destruction, type 2 diabetes due to insulin resistance and progressive insulin secretory defect, gestational diabetes, and other specific types of diabetes like the monogenic diabetes syndromes, like neonatal diabetes or maturity onset diabetes of the young, diseases of the exocrine pancreas like cystic fibrosis, drug or chemical induced diabetes. How to diagnose diabetes? You first diagnose that it is diabetes and then you diagnose. And of course, the diagnosis is whether using the symptoms of the signs or the lab diagnosis, as we said, and as you see here on the slide, and then you diagnose the type. The pre-diabetes stage, as we said, is diagnosed by these lab values, which we have just mentioned before. And this table shows how to differentiate type 1 and type 2 diabetes. Of course, type 2 diabetes more in adolescence. Obesity is more common in type 2 diabetes. Females are more affected than males in type 2 diabetes. Family history is more prominent in type 2 diabetes. Autoimmunity in type 1. C-peptide is low. Ketoacidosis more frequent in type 1. And associated autoimmune disorders occur like thyroid, adrenal, vitiligo, or celiac disease. However, type 2 diabetes is more associated with signs of insulin resistance like acanthosis nigricans, polycystic ovary syndrome. The management of type 1 diabetes, we're going to speak about the insulin therapy, the blood glucose monitoring, the nutritional management, and the importance of exercise and sports. What about insulin? Of course, the golden rule is using intensive insulin therapy. Multiple daily insulin injections using the basal bolus concept. You give a basal insulin that gives a background insulin, and then you give bolus insulin with the meals. You can deliver it through syringes, pens, action. How to calculate the dose? The dose is usually between half to 2 units per kg per day. We give half the dose basal insulin and half the dose prandial insulin, and the MPH is given twice per day, while the basal analogs are given once per day. You calculate the dose, the 50%, and then you give 70% of the calculated dose at bedtime, while the prandial insulin, you just divide them over the main three. So it's really challenging having diabetes in adolescence because during puberty, the energy intake, the nutritional demands increase. The sex hormones lead to insulin resistance. These children in this age group are rebellious. They are non-compliant to treatment or to diet regimens. They frequently skip the insulins or they miss the meals. They stay out late and they take excessive blood glucose because really blood glucose monitoring is very important in diabetes. If you get 1% less in hemoglobin A1C over 10 years, you may get a 20% less in the incidence of complications. This can be done by finger pricking using the self-blood monitoring to try to reach the target. Hemoglobin A1C less than 7, pre-meal 70 to 130, post-meal 90 to 180, and pre-bed 80 to 140 milligram per deciliter. But mind you, these targets are individualized according to each child to balance between preventing hyperglycemia and also preventing glycemia. And it's really very challenging in children to achieve the target because children are growing, they have variable exercise and eating patterns, There is critical cognitive development, fear of hypoglycemia, a high physiologic and psychologic burden of disease, the difficulty in achieving diabetes care in school, and the dependence on the carers and can be traced. The nutrition of the hypertension. Through nutrition, you can maintain as near normal the blood glucose levels by coordinating the insulin with the diet, with the physical activity. You can ensure an optimal blood pressure and lipid levels. You can give adequate calories to ensure appropriate weight management and appropriate development. Manage risk factors, prevent complications, improve overall health through healthful food choices, and of course, you should address the individual nutrition needs to incorporate the personal and preferences. But how? How to prepare the meals? Let us take this example of a 10-year-old female with diabetes with moderate activity who needs 1,800 calories. The carb should constitute 50 to 55%, the fats 25 to 35%, while the proteins from 15 to 20%. So if the total calories are 1,800, 900 should be from carb, and because every 1 gram gives 4 calories, so this patient or this child needs actually 225 grams of carb per day. That should be divided over the 3 meals and the 2 snacks. We use an easy way of calculating the carb in the meals, which are the exchange points. We offer them a booklet which contains different servings of carb. Every serving contains 15 grams, which means 1 point. So if this patient needs 15 points, this means that every point is actually a 15 carb. But what type of healthy carb? The fruit, for example. One small fruit, 120 gram is 1 point. Starchy vegetables, one small potato, 120 gram is 1 point. Whole grain, a bread slice or 3 spoons of cereal is 1 point. 3 spoons of legume is 1 point. Low fat milk, small. Concerning the fats, we should always advise the child to avoid the bad fat choices. No saturated fats present in the fatty meats, cheese, ice cream, full fat dairy products, high fat snacks, and no trans fat present in the margarines, the cupcakes. But the good fats choices are the monounsaturated fatty acids and the polyunsaturated fatty acids present in olive, sesame, nuts, pea butter. The MUFA should constitute 20%, and the polyunsaturated, the PUFA, should constitute 10%, the corn, the sunflower, the soybean, or the fatty fish. Anyway, total cholesterol in food should be less than 300. So how can we calculate this? We just divide 450 or 500 by the total daily doses. I invite you to Google my chapter about the nutritional management of type 1 diabetes. If you just open Google, you write nutritional management of type 1 diabetes, Shereen Abdelghaffar, you can freely download this chapter, which contains all the important data that you need to know about the nutritional management of type 1 diabetes in children. The fourth pillar in the management is stressing the importance of performing in sports. Because what are the benefits? It leads to improved glycemic control, decreased insulin dose because of the increased insulin sensitivity, the weight control due to energy expenditure, the reduction in comorbidities, hypertension, dyslipidemia, cardiovascular disease, improved mood, quality of life. All these are important to prevent the acute complications, and the most important is the DKA. And of course, you know DKA, hyperglycemia, metabolic acidosis, ketonemia, and or ketonuria. And the goal of management is to correct the acidosis through expansion of the intravascular volume, correction of the deficits in fluid, electrolyte, and acid, base status, initiation of insulin therapy, assessment and monitoring of therapy. I invite you to come to our unit, DEMPO, Cairo University, and take your copy of the guidelines of the diagnosis and the management of DKA in children. The screening should be commenced at the age of 11 years. Remember, you can screen for dyslipidemia in the non-fasting state and screening for kidney disease by using the first morning samples and assessment of albumin creatinine ratio, 2 or 3 samples more than 30 microgram per milligram in males or 42 microgram per milligram in females is considered positive. 2 of 3 samples in this period. And as I mentioned before, prevention is better than cure. Remember the cause of type 1 diabetes, that diabetes, if not properly managed, can affect growth, can affect puberty. Insulin may lead to weight gain if not given in the proper dose. Type 1 diabetes, being an autoimmune disease, can be associated or combined with other autoimmune conditions like thyroid disorders, celiac disease, adrenal insufficiency, or vitiligo. Please take care for bone health and oral health control. And of course, this cannot be done by one member alone. It needs the cooperation between the diabetologist, the pediatrician, the nutritionist, the dietitian, the psychologist, and other healthcare professionals. And the role of the diabetes educator is very important to teach the child and the parent all about the insulin, all about the food intake, and how to manage the sick days, how to prevent the hypo and the hyperglycemia. So it's really a multidisciplinary diabetes management. So at the end, let's work all together for all diabetics towards a happy, healthy life through childhood to adulthood. Thank you and goodbye.